medical director of Integrative and Holistic Medicine, and she's going to talk about integrative oncology for prevention and treatment of breast cancer.
Thanks, everybody. I'm very happy to be here, and you'll be happy to know I only have one slide with a chemical equation in it. My disclosures have absolutely nothing to do with what I'm talking about today, which is what I'm very passionate about, which is the prevention of breast cancer from a lifestyle modification and holistic perspective, and how we improve our patients' quality of life. Over the past year or so, there's been a change from complementary and alternative medicine to complementary and integrative medicine. And I think it was a very big switch because we're really not doing anything that's alternative to traditional Western medicine. We're just integrating things that we know can make a difference in our patients' lives. If you look at 1946, the cover of Life magazine, on the back cover, more doctors choose to smoke Camel cigarettes than anything else. And so if you think about the things that we believe to be true in our lives, in 1946, doctors were telling patients that it was not harmful to smoke cigarettes. And I think I can, for the last time in my talk, say, I think we can all agree that our patients shouldn't be smoking. So what is this really about? An integrated, holistic approach to breast cancer risk reduction. When patients come to my office and say, Dr. DuPree, I know I'm getting scans, I'm getting blood work, but I don't want my cancer to come back, what can I do? And one of the things that is the most agonizing process for me is listening to the fear in their voices. If I cure someone of stage 1 breast cancer and they sit in their kitchen with their lights off in the dark, depressed, waiting for their cancer to come back, I haven't really done the very best that I can do for that patient. So what I'm going to look at today is how do we approach this safely, effectively, and what knowledge can I give you to take home? So when we look at QOL, or quality of life, many times we're actually looking at studies that are recommending and looking at quantity of life, survivorship. I look at the survivorship of a patient not only in the amount of time that that patient has after a cancer diagnosis, but I also look at the quality of life that they have as well. Because to me, we can't look at one without the other. And this requires us to look at the whole concept of body, mind, and spirit, because balance within this is very important. So when we look at studies, prospective randomized studies, looking at risk recurrence reduction in 1,500 women early stage breast cancer, it was simple. They ate 5 fruits and vegetables a day, walked 30 minutes, at least 30 minutes 6 days a week. They were able to get a 50% reduction in the risk associated with recurrence of breast cancer. And the important thing was this was in patients that were both obese and non-obese, so it wasn't just about their size, it was about changing their lifestyle behavior. Again, in a very, very large study of 70 different trials, in pre- and postmenopausal women that were ER positive, women with a BMI over 30 had an increased risk of relapse and death. These are topics that we need to talk to our patients about. In postmenopausal women that had a BMI over 40, they also had a significant increased risk. Their adjuvant therapies are less effective, and they also have increased risks of lymphedema, which decrease the patient's quality of life. The study looking at survivorship, stage 2 and 3 breast cancer patients, healthy diet, physical activity, stress reduction with yoga, and additional social support given over a course of 4 months and then 8 months, with a total of 39 therapy hours, had a 56% reduction in mortality and 46% reduction in recurrence. These are real numbers. There's a real survival benefit to being able to integrate very simple aspects of integrative holistic medicine into their care. So exercise. I've seen a lot of you in the gym, very happy about that. Ran across a few of you on the path outside. And we know that exercise makes a difference. The duration of exercise, 36 months past diagnosis, changed the patient's risk of recurrence and disease-specific mortality. So what we're doing with the exercise is we're actually changing how our bodies are metabolizing what we eat. So when our patients come to my office and tell me that they're going to treat their diet they're going to treat their cancer with a vegan diet, or they're going macrobiotic, this is one of my most difficult conversations because the diet is very, very important, but it absolutely is insufficient to treat cancer itself. Nutrition is very important. We need to nourish the body so that it can tolerate many of the things that we ask the body to compensate from with radiation and chemotherapy. But we need to continue to use nutrition as a way to boost our immune system and not as a method of treating the cancer itself. Stress reduction is huge. Poorer survival and higher cancer mortality in patients that do not have any stress reduction modalities in their life. Based on these results, we can encourage patients to become active participants in their stress reduction. So how many of you haven't heard about the fatigue coming from radiation therapy? So there's 3 ways we can combat this. Number 1, exercise. Whether it's cardiovascular exercise or whether it's strength training, patients have been shown to have decreased fatigue and severity of their symptoms by exercising with both cardiovascular and resistance training. A lot of these studies are very small, but they're prospective and randomized, and to me they're the very beginning of us learning how we can change the downstream effects of the therapies that our patients so desperately need. Yoga is something we're just integrating into our own program, looking at yoga compared to gentle stretching, compared to the weightless patients. The yoga patients have improved quality of life and physiologic changes that are far beyond what they got just from the stretching exercises themselves. Wisconsin ginseng was something that my radiation oncologist turned me on to when it was in the radiation oncology literature, looking at a prospective randomized study, 40 different institutions, double-blinded, using 200 milligrams of American ginseng. And it's important that you know the type of ginseng your patients are taking because it depends. Ginseng that's derived from the ethanol extraction can have estrogenic properties, so you want to make sure that it's derived from water extraction. Tai Chi and cognitive-based therapy for the treatment of insomnia. The Tai Chi was superior and actually showed cellular changes in interleukin-2 and tumor necrosis factor. So phytochemicals. A lot of patients will ask you, should I be taking vitamin D? Should I be taking omega-3s, green tea? There's a tremendous amount of potential benefit from these supplements, or what we call biologically active compounds. But remember that these are active compounds, just like Taxol comes from the Pacific yew tree, and aspirin comes from the bark of a willow tree. It's very important for you to know what your patients are taking. I had a patient die from taking horse chestnut for her varicose veins. She shut down her liver after surviving stage 3 breast cancer. So this conversation is very important. You need to know what your patients are taking. So the Society of Integrative Oncology puts guidelines out every 3 years that look at how these survivorship tactics and integrative modalities improve our patients' quality of life. And what they're looking at is getting rid of anxiety, depression, fatigue, the chemotherapy-induced nausea and vomiting, lymphedema, and neuropathy. So when they put out these guidelines, they're looking at different gradations. A and B are categories that are recommended. C, A and B are easy, meditation, mindfulness-based stress reduction, relaxation. All of these have been shown in prospective randomized studies to improve patients' quality of life. They have no harmful effects. Therefore, the benefits far exceed any other reason why you wouldn't want your patient to do this. 68 to 80% of our patients are seeking these modalities, whether you know it or not, and so we need to know about them. The grade C category are shared decision, and so if a patient's going to take something that has a biological activity, it needs to be discussed with you so that you make sure that it's not interacting with anything they're taking. There have been studies that show that pomegranate can interfere with Herceptin, and I certainly wouldn't want one of my patients to not have the benefit of Herceptin by taking pomegranate every day, thinking that they're improving their nutritional factors. So the grade H is the harm, and the only thing that is really in that category at this point is the acetyl N-carnitine, which can actually be harmful and should be avoided in patients. So breast cancer prevention. This is really what it's coming down to for all of us, because we know that we're not getting any less busy. We know that the patients are still coming to our office, and despite the fact that there's breast surgeons in all the hospitals surrounding you, there's no lack of patients showing up in your office. So there were several studies that have been done that look at what can we do to prevent breast cancer. This is a study that came out in 2012 looking at night work and the circadian rhythm disruption. And because we believe that melatonin has some anti-carcinogenic and antioxidant mechanisms, the sleep disturbance patterns are very important to look at as potential ways for us to educate women about their risk. The Cecile Study was done looking at population-based nurses that were at increased risk, and they evaluated these women who develop breast cancer, looking at multiple things that we know make a difference. Their menarche, the age of the birth of their first child, whether they've had hormone use, alcohol consumption, BMI, and then they looked at their sleep patterns and work patterns. And what they found that women that work overnight shifts greater than 4.5 or more years, and for shifting their shifts less than 3 times per week. So if somebody does night shift all the time, their circadian rhythm can recover. If a woman is doing constant flip-flopping of their shifts, they're certainly at higher risk. And what they found was women prior to the birth of their first child were at the greatest risk if they were in those night shifts. And that's what's happening to young nurses in our country when they get a job. They typically get the night shift and they're swinging back and forth. So one of the take-home messages is that they can try to create a schedule that's going to give them less shifting of their circadian rhythm. It's going to be beneficial. So only 15% of our U.S. population is considered sedentary. I don't really believe that statistic. I think it's worse. 40% of our nation falls under the guideline of what we should be doing to be active. Our lifestyles have changed. 3 to 4 hours of vigorous exercise a week can reduce a woman's risk of breast cancer by 20 to 40%. The last time I checked, those are about close to what we're offering women with risk reduction with tamoxifen. So here's the big take home, and I know when I see all of you at the bar tonight, you're going to be cringing. Alcohol, 1 unit of alcohol increases your risk of breast cancer by 7 to 10%. And unfortunately, ladies, if you like your glass of wine, a 4-ounce pour of wine is 1.5 units. So what's recommended is alcohol in moderation. I know you're all having your annual alcohol allotment this week, so I'm not going to say a word. But we should all try to do 2 alcohol-free days per day. Folic acid has been shown to protect the effects of alcohol. And the recommendation has been that women shouldn't really be drinking alcohol before the birth of their first child due to the risk on their breast tissue. So this is not 1 glass of wine. So lifestyle modification. If we look at this and take away our take-homes, about 40% of postmenopausal breast cancer can be prevented by reducing alcohol consumption, maintaining a healthy BMI, and regular exercise. If we add tamoxifen for prevention or an aromatase inhibitor in a high-risk population, we can get that up to about 50%. Unfortunately, less than 49% of women who need to be on tamoxifen for treatment actually stay compliant on it, so that's a real concern for me. Diet and exercise can be part of every day. So if we look at how many annual breast cancers we're seeing, we want to cut that in half. What we need to do is change our risk stratification and modify our lifestyle. Unfortunately, last week's ASCO post is showing that we're going to have about a 50% increase by the year 2030. It's only 15 years from now. And these are not HER2-positive cancers. These are not triple-negative breast cancers. These are lifestyle modification breast cancers that are estrogen receptor-driven. So nutrition in and of itself is not enough to make a difference. Exercise needs to be combined with nutrition for us to be able to get to a place where we become healthy. Cliff Hutt has said it very well. Any way we look at this, obesity is slated to replace tobacco as the leading overall modifiable risk factor for cancer. We're going to have to tackle this problem from a public health point of view. And now that we are getting into a place of much more managed care and the medical home, it's going to become our problem as well as primary care physicians of the breast. So our belly fat matters. This is the big deal. The Nurses Health Study looked at postmenopausal breast cancers. For every 5 kilograms per meter squared increased BMI, the cancer risk ups by 12%. People who reduce that risk also reduce the risk of cardiovascular disease and diabetes. So the body weight matters, and a 10-pound reduction in 200-pound women can decrease the risk of breast cancer by from 25 to 40%. It's a big deal. So here's your estrogen. When patients say to me, I'm postmenopausal, my ovaries aren't working, and I say, what lives between your breasts and your belt is what I'm concerned about. So this is my 1 chemical compound. As you can see, we start out with cholesterol, we go through multiple different pathways, and we end up with estradiol. And what happens is, it's that methylation group from the aromatase. And if we can get rid of some of the substrate, we're going to be able to get rid of some of the downstream estrogen. So a recent study, 2 recent studies looking at lifestyle modification, 60% reduction in cancer-specific mortality, Mediterranean diet, being physically active, not smoking, and moderate alcohol use. It's a big deal, and it does make a difference. This just came out in 2015. Decreased risk of all cancers and death from cancer of all causes. The more you adhere to it, the more you get a decreased risk. It's a prospective lifestyle study on almost 500,000 individuals. And the BMI was still the biggest factor in women for the risk reduction. So here's the take home. This is mold. I hate to admit this, but this is in the bathroom being redone at my house. Cancer's the mold. We treat the mold. We treat breast cancer every single day. The Clorox did an amazing job of alleviating the mold. But if you don't open the window, change the ventilation, change the light, the mold comes back. So a disease that's created by lifestyle cannot be cured without lifestyle changes. The conversations we have with our patients, you don't tell a woman that she's fat, you say you have an opportunity for improvement. I talk about this in my very first breast cancer consult under local disease, systemic disease. The first thing under systemic disease is lifestyle opportunities for improvement. We give our patients some very important information. We give them 31 ways to help reduce the risk of breast cancer if they're there for something benign. And we give them a very simple nutrition guide because we really don't know enough about nutrition in this country as physicians. Thank you for your time.